So for this WebEx, before we get started, I'm just going to let you know you'll need your ICD-10 book again. We're going to continue going through our ICD-10 guidelines, and you'll also want to have your medical training manual, because I'll show you how to follow along with that. But we still have a couple minutes, so I'm just going to go ahead and mute the line, and then we can start at exactly 10 o'clock. Okay, so it's 10, so we're going to get started. We're going to be covering our guidelines today, important parts of our guidelines for the exam, as well as just understanding our ICD-10 guidelines. And we have a couple of questions to answer. And also, I wanted to just spring a little quiz on you guys. So obviously, you guys can chat to me the answers, or just keep them for yourself, and we can go over them together. But I'm going to go ahead and pull up our whiteboard, and you guys should all be able to see this right now. So without referring to the index of diseases and injuries, underline the word that indicates the main term for each of these diagnoses. So I want you guys to look at these and figure out what is the main term. So the main term would be what you would start with in the index to look the code up. So I'll just give you a few minutes, actually probably like 1 or 2, and then we'll go over the answers together. So a lot of them make sense, right? Number 1, acute myocardial infarction. Well, oops, I still haven't mastered the whiteboard. I'm so excited to use it, but I'm not very good at it. So our main term here, infarction, right? There has to be a straighter line. How about we use the arrow? So chronic hypertrophy of tonsils and adenoids. Main term here would be hypertrophy. Let's go like this. There we go. So some of them are a little bit, self-explanatory, and some of them aren't. Remember, for these main terms, this is what you would look up in the index to get to the code if you were properly coding. So acute suppurative cholecystitis. Now, cholecystitis is our correct answer. And, then the aneurysms, so syphilitic aortic aneurysm, you would start by looking up the main term, aneurysm. And so most of them are pretty self-explanatory, right? Well, what about this next one? Normal spontaneous delivery, full-term infant. For these, you'll always start with the main term of delivery. Okay, and I will actually, don't worry about like copying this down. We'll post it. We have it in a pretty format, and we'll post it to PDF right after this WebEx. So you guys can access the main term and the answers to this. Drug overdose due to barbituates. So what do you think? Overdose? You're right. Urinary tract infection due to E. coli. And this is an interesting one because this one always gets confused with sepsis, especially in ICD-9. It could be documented as sepsis, which is a very serious condition, but really it's a urinary tract infection due to E. coli. So that's an interesting side note, but as you get more familiar with coding, we'll get into those kind of tips and tricks. But for urinary tract infection due to E. coli, main term here, infection. Hemorrhagic pneumonia. Again, disclaimer, my pronunciation is just not very good. Hemorrhagic pneumonia, right? And then admission for adjustment of artificial arm. This one's kind of tricky too, but this would be our admission. And our last little quiz, bilateral inguinal hernia, and our term here is hernia. So this is just practice for you guys to really, learn. Let's just make that little, it's my OCD. Let's just point to the infarction too. This is really for you just to get familiar with identifying main terms as you are coding. So let's get out of there. And let's go to a new share and let's get to our guidelines. Okay, so I was so excited to use the whiteboard, but that didn't look as pretty as I expected it to. So more to come with that whiteboard. Okay, so we ended last WebEx with borderline diagnosis, and we were just getting into using signs, symptoms, and unspecified codes. So right after we cover this, I'm going to show you guys different guidelines in your book, these same guidelines in your book, but in a different place. But let's get through the use of sign, symptom, and unspecified. So as you remember, we are following along with our actual ICD-10 guidelines in our book, right? And so this would be on page 5 of your coding guidelines. If you're in the 2016 book, I know some of you have the 2017 book. And unfortunately, that doesn't go along exactly with the class. So use of sign, symptom, and unspecified codes. So this is really, you're only going to use these in situations when the signs, symptoms, and unspecified codes are the best choice, right? So if there's a more specified diagnosis, you would never use a sign or symptom. You would never code a sign or symptom. Now, inpatient rules are a little bit different, and once we cover the inpatient rules, you'll be able to differentiate between the two. But for outpatient coding, signs, symptoms, and unspecified codes are never used if a more definite code is used, documented, and also, like we briefly talked about this, if you have strep throat and you're getting treated for strep throat at your PCP, and he documents sore, scratchy throat, strep throat in the assessment and plan. And so the coder goes in there and they're like, okay, so we have sore throat, strep throat, and I need to code these conditions. Well, you're not going to code the sore throat because the sore throat is an integral part of strep throat. And so you're only going to code the strep throat. And so anytime a sign or symptom is an integral part of a condition or a disease that's already documented, you're only going to code that documented, more specific code that symptom or sign is an integral part of. And again, with unspecified codes, so there's lots of unspecified codes. And a flag to see in an unspecified code is it ends with a 9 or an 8, right? Not all the time, but most of the time. So when you see a code ending with those numbers, that just can kind of be a flag in your head. This is unspecified. Is there a more specified choice? I should look for that. In ICD10 in 2017, they are going to get a lot more, they're mandating that the unspecified codes are really used only in the unspecified situation. So when ICD10 first came out in October of last year, CMS said that, you know, they'll be a little bit flexible because there's so many new codes and it's such a big change from ICD9 to ICD10. So they were going to be a little flexible with the coders and the physicians and anybody else submitting codes. And now they are cracking down on it. They want, and they will be watching to see if unspecified codes are used when a more specified diagnosis is available. How do they watch? Through audits, through data mining. So we just really need to be sure that if there is a specified code, that's the code we're selecting. And for the exam especially, you know, if you see CKD, and then in the medical record you see CKD4. So you aren't going to code both of those, right? CKD unspecified or CKD stage 4. You'll only code the CKD stage 4. Okay, so remember, any questions, just send them our way. So we're going to get into our chapter-specific coding guidelines. And so this is what I really wanted to show you guys. I don't know if you're aware yet that there's guidelines in front of each chapter in your ICD-10 book. And so I'm going to change my screen really quick and share this. So this is the exact same guidelines we're about to go over with examples, okay? And this is also uploaded in PDF under our ICD-10 section for current students. So you can actually download just this part of it. These are all of the chapter-specific guidelines, but these are in front of each specific chapter. So they're at the beginning of the book all together, and then they're in front of each chapter they pertain to, okay? So this is page 423 for the 2016 books. And we're just going to go follow along our guidelines using this. And we did this, we covered the HIV before, but we're going to just go over it again using this method. Okay, so HIV is, you know, it's one of our, obviously a very serious condition, and we really as coders need to make sure that we are coding it appropriately. And you can imagine why. As a coder, you actually can give somebody a condition they don't have if you select the wrong code. And so it's very important in overall that we're just certain about the codes that we're selecting. With that being said, everybody makes mistakes, so don't freak out. But if you see HIV in the record, I would just zone in on it and do your best to select the most appropriate code. So with that being said, our first little guideline there is code only confirmed cases. So that's self-explanatory, right? We're only going to code confirmed cases of HIV infection illness. This is an exception to the hospital inpatient guideline. So again, hospital inpatient guidelines are a little bit different, and they're not too different, but there's little quirks to them. And so we'll cover those after we're done with all of this. Okay, but they're already uploaded onto our current student section if you'd like to just jump ahead and look at them. You can download them in PDF. Okay, so in this context, confirmation does not require documentation of positive or serology or culture for HIV. The provider's diagnostic statement that the patient is HIV positive or has an HIV-related illness is sufficient. So here's our example. And this is why I love this way the guidelines are broken down independently by chapter, because they give us these great examples, right? So we have anemia unspecified. And our explanation, only the anemia, okay, well, here's the scenario. Patient admitted with anemia with possible HIV infection. What would we code? We would only code D64.9 anemia unspecified. And our rationale or our explanation is because the anemia is coded in this scenario because it hasn't been confirmed if the HIV is present, right? And so again, that's an exception to inpatient guidelines, but we'll cover that later. So this is just saying, because of the way that the documentation is read, patient admitted with anemia with possible HIV infection, we would never capture that. Our next guideline, patient admitted for HIV-related condition. If a patient's admitted for an HIV-related condition, the principal diagnosis should be, now it's going to give us our code, B20, human immunodeficiency virus HIV, followed by additional diagnosis codes for all reported HIV-related conditions. So here's our case study, HIV with PCP. B20 for the HIV disease, and then B59 for the pneumocystosis. And our rationale is pneumonia due to pneumocytosis is an HIV-related condition. So the HIV diagnosis code is reported first, followed by the code for the pneumonia. Let me just show you guys again in your ICD-10 book. These are at the beginning of each chapter, right? These are the beginning of our chapter sections. Our guidelines are there. Think about how great of a reference this is for the test, okay? So we just read that. So we just read an HIV diagnosis code is reported first, followed by the code for the pneumonia. That's letting us know right there that our sequencing rules, right? So we would sequence the HIV and then the HIV-related illness. So if you have a question on the exam, and it's this question, okay? And one of the answers is, since it's multiple choice, A is B59 and B20. And answer B is B20 and B59. And then C and D or whatever. So you would know, because you know where this is in your book, that you could just go here and verify that what you're thinking is right. HIV is coded first. And so you'll know right away that your answer is B. And that's kind of how the test goes, right? Everything you need to know is in your book, or you can put it in your book, and you just need to know how to get there. Okay, so moving on. Patient with HIV disease admitted for unrelated disease, right? So if a patient with HIV disease is admitted for an unrelated condition, like a traumatic injury, fracture, the code for the unrelated condition should be the principal diagnosis. Other diagnosis would be B20, followed by additional diagnosis for all reported HIV-related conditions. So our case study here, unstable angina, native coronary artery arteriosclerosis, and HIV. Okay, so we actually have 3 diagnoses, but two of those diagnoses are coded together. So the unstable angina and the coronary artery arteriosclerosis are coded together, which is great. One less code we have to worry about. So our coding sequencing and code selection here would be the unrelated condition as the reason the patient is being admitted, and then the HIV. So we have I-25.110 for the arteriosclerotic heart disease of native coronary artery with unstable angina pectoris, and B20 for the HIV disease. And we have rationale, the coronary artery disease, and the unstable angina are not related to HIV. So those conditions are reported first using a combination code, and HIV is reported secondarily. And so you see the difference between guideline 2A and guideline 2B. It's really why the patient is admitted. That's the only thing that's changing the order of the code selection. If the patient's admitted for an HIV-related condition, then you would code the HIV disease first. If the patient is related for an unrelated condition, admitted for an unrelated condition, you would code the unrelated condition and then the HIV disease. Okay. So now we're moving on to guideline 2C, whether the patient is newly diagnosed. So whether the patient is newly diagnosed has had previous admissions encounters for HIV is irrelevant to the sequencing decision. Newly diagnosed multiple cutaneous Kaposi's sarcoma lesions in previously diagnosed HIV disease. So just because the patient has a newly diagnosed HIV-related condition, the Kaposi's sarcoma is still coded second. So we can see here that the B20 HIV disease is coded first, followed by Kaposi's sarcoma of the skin, C46.0 second. And our rationale, even though the HIV was diagnosed on a previous encounter, it is still sequenced first. When coded with an HIV-related condition, Kaposi's sarcoma is an HIV-related condition. And Kaposi's sarcoma is actually always an HIV-related condition if it's documented in HIV. So this is a good point because I will definitely make sure to get you a list. Let me make a quick little note. To get you guys a list of common HIV conditions. In fact, I think it's in your workbook, but I'll just get it on the current students portal too. Okay, so guideline 2D, asymptomatic human immunodeficiency virus, Z21. Asymptomatic HIV infection status is to be applied when the patient without any documentation of symptoms is listed as being HIV positive, known HIV, HIV test positive, or similar terminology. And we would not use this code ever if the term AIDS is used or if the patient is treated for any HIV-related illness. Or is described as having any condition resulting from his or her positive status. Use B20 in all of those cases. So the takeaway here, Z21 asymptomatic HIV infection, only used if the patient has never had any HIV-related disease that you can tell of, any HIV-related condition, has never had any conditions as a result of their HIV disease, and that it is not referred to as AIDS. Once a patient has AIDS or any of these HIV-related illness, they'll never have this asymptomatic HIV code again. Once you go from Z21 to B20, you never go back again. Okay, so here's our example. Patient admitted with acute appendicitis, status positive HIV test on Atripia with no prior symptoms. Oh, I can make this bigger. Oh my gosh. See, I'm a little technology. I need help. So anyways, I was struggling to read that. Now I don't have to anymore. Okay, so we have a tripla with no prior symptoms. So our coding here would be the K35.80 unspecified acute appendicitis, Z21 for the asymptomatic HIV disease, HIV infection status, that's important, and our rationale. Code Z21 is sequenced second since documentation indicates that the patient has had a positive HIV test but has been asymptomatic. Being on medication for HIV is not an indication that code B20 is used instead of Z21. So that's an important thing to note. I would highlight that for sure. Being on medication is not an indication that code B20 is used instead of Z21, unless there has been documentation that the patient has had current or prior symptoms of an HIV-related complication. Code B20 is not used. The appendicitis is not an AIDS-related complication and is sequenced first. Okay. Let's see, hold on one second. We're going to take a quick little pause. Sorry about this. I just got a flag about our meeting, so I just want to make sure it doesn't end on us. That's strange. Okay. Let's see. So if we disconnect, we'll have to just, I'll send you guys an invite right back and we will connect again. Let's see. Okay. Okay, let's see. Okay. Okay, well, we might get disconnected and then I'll just re-invite you guys again. I started the meeting too early, I think so. Anyway, just bear with me. Let's see. Okay. Okay, back to him. Okay, so we have chapter specific HIV guidelines A, and now we're on E. Patients with inconclusive HIV serology. Patients with inconclusive HIV serology but no definite diagnosis or manifestation of the illness may be assigned code R75, inconclusive laboratory evidence of HIV. So like in that scenario, they don't know. They gave an HIV test. They don't know for sure that it was a definite positive result. So it would be coded to R75. And remember, R, codes that begin with R are a flag to us that it's a symptom. So you would have an R75 and then the patient would have to come and get additional testing. So F, previously diagnosed HIV-related illness. So patients with known prior diagnosis of an HIV-related illness should be coded to B20. Once a patient has developed an HIV illness, the patient should always be assigned code B20 on every subsequent admission encounter. Patients previously diagnosed with HIV illness B20 should never be assigned R75 or Z21. And Z21 is the HIV infection status. So that's important to remember. Once you're B20, you're never going to be R75 or Z21 again. G, HIV infection in pregnancy, childbirth, and the puerperium. During pregnancy, childbirth, or the puerperium, a patient admitted or presenting for a healthcare encounter because of an HIV related illness should receive a principal diagnosis of 098.7 and whatever digits are applicable, HIV complicating pregnancy. And codes from chapter 15 always take sequencing priority, and that's the OB codes. And patients with asymptomatic HIV infection status admitted for presenting for a healthcare encounter during pregnancy, childbirth, or the periperium should receive codes of O98.7 and Z21. Okay, and